Okay. So we're going to go over blood transfusion first, okay? So you're going to have some questions about that. Now, realize that we all have a blood type, meaning we have a blood type that is specific to us. The term antigen means it's a marker on our cells. All of our cells are marked because they belong to us, okay? And I use antigen as like, okay, everybody has that crazy antigen. You know, she's a little out there. She might drink a little gin. She's a little crazy. But when she's with you, it's cool. You love her because she's your antigen. But if I try to bring my crazy antigen over to Michelle's house, she's going to be like, no, this lady's whacked. Get her out of here. She is going to disturb the peace in her house. That's the same thing with an antigen on our blood cells. And I tell students, don't ever give someone something, an antigen they don't already have, or they're going to react to it. Does that make sense? So if I have type A blood, I have type A antigen. Do I have type B antigen? Nope. And if I have type B blood, I have the B antigen. Right? This is not rocket science, really. Seriously. And if I have O, I am open, meaning I have neither the A nor the B antigen. Now, we're going to talk about the Rh factor, but let's just get through ABO compatibility first. Does that make sense? So, obviously, if I have to give somebody a blood transfusion, they're anemic, they've had trauma, whatever, we have to increase the prime, that precious prime. Remember, perfusion, what this B says, is the pump pushing the precious prime precisely through the pipes to the point of purpose. We need the heart, the pump, to push the precious prime, which is our blood and our plasma. We have to have enough water in the river through our pipes to the point of purpose, which is every cell in the body, because every cell in the body works aerobically. We need to have oxygen in order to make ATP, right? ATP is our power for every cell. So we want to make sure if we have to give somebody blood that we check it closely. We need to start a line. We want a fresh line. What size cath do we want? IV. 18. If you go down to a 20, sometimes you have to because the people don't have veins, but you can start hemolyzing red blood cells. We want a big open cath so that the blood can run through it. What type of fluid do we use? Normal saline, because it is isotonic. Remember, iso is so to increase flow. In isotonic, it's not going to dehydrate the red blood cell, nor is it going to make it expand. Okay? So we use normal saline. That is the only fluid that is compatible with a blood transfusion. And you all know that if you go get blood, you can send the PCT down to get the blood, but who has to check the blood? 2 nurses, right? And they verify it with the patient's band. And then a nurse has to stay in the room for how long? We check their vital signs before, right? And then we stay in the room for 15 to 30 minutes, because most of the time if somebody's going to have a hemolytic reaction because we've given them the wrong antigen and we've cranked up their body and their defense systems, it's going to happen within that first 15 minutes. We're going to talk about the difference between hemolytic and febrile reactions. Okay, so if I have the A antigen and I'm telling you, you can only give somebody what they have, don't give them something they don't. What I could definitely give them themselves A, correct? But I can't give them B, can I? Because it has an antigen. What about O? Yeah, because there's no antigen, so I'm not giving them something they don't already have. So they can get A and O. Now, if you have the B antigen, your B type, then obviously we can give them what they are, which is B, and we can give them O, BO. Okay. But we can't give them A, because that would cause an antibody reaction. Remember, an antibody is a protein that goes and is specific and destroys different antigens, okay? And O, poor O, doesn't have any antigens. I can't give it A antigen. I can't give it B antigen. I can only give it itself, which is O. Okay, does that make sense? Now, where it gets a little crazy. Oh, by the way, I forgot about this. We have AB blood. That person has the A antigen and the B antigen. So I can give them themselves AB, and I can also give them A and B. They can take it all. They've got all the antigens. So I'm not giving them anything they don't already have. Make sense? Now, the RH factor, remember we talked about this in OB. You either have it or you don't. So if you have it, I'm not going to be giving you something you don't already have. But if you don't have it, and I give you RH positive blood, you're going to develop antibodies to destroy that blood. Okay? So if somebody's RH negative, don't give them RH positive. But if they're RH positive, you can give them positive and negative. Yes? By the way, this is informal. If you have questions, you raise your hands. So let's go here. If somebody is A negative, then they can have what? A negative. They can't have A positive, can they? And they can't have anything in the B realm, but they can have O negative. Okay, very good. If they're A positive, they can have A positive and A negative, because I'm not giving them something they don't already have. And I can give them O negative, and O positive. Okay? Now, they might be B negative, so then they can have B negative. Can they have B positive? No. Absolutely not. Can they have anything in the A's? No. And what can they have with O? All right. Now, they can have AB negative, and they can have, obviously, AB negative. They can have A negative. Can they have A positive? No, no RH factor. Can they have B negative? Yes. B positive? No. Can they have O negative? Yes. O positive? You guys are getting this. Then we have O positive can only get O positive or O negative. I forgot AB positive. AB positive, they've got every antigen known to man. You're not going to give them something they don't already have, so just throw it at them. Okay? So they can have AB positive, AB negative, A positive, A negative, B positive, B negative, O positive, O negative. They are the universal recipients. Poor little O neg like me can only get O neg. This O neg is the universal donor. If we have a trauma patient coming in and we don't have, they're hypovolemic, we need to give them blood stat, but we don't know, we haven't typed and cross-matched yet, we're going to give them O negative because there's no antigens in O negative. Does that make sense? Yeah. Okay, so now make sure that you understand that what the difference is between packed cells, whole blood, and fresh frozen plasma. So with packed red blood cells, we use that to treat hypovolemic shock or anemia. It's about 250 to 300 mils, and that's going to expand our blood component in the pipes. It helps increase for every 1 unit the hemoglobin by about 1 gram. What is the normal hemoglobin? By level 4, you guys got to know your labs. Think about this. Who's growing the fastest, needing the most hemoglobin? Teenagers. Okay, between the ages of like 12 and 15. And then just triple it for your crib. So we want a hemoglobin of around 12 to 15, maybe a little less for an adult. But we used to transfuse people when they got down to 10. Not anymore. Sometimes we'll wait till 8. I've even seen them wait till 7 or 6, which I think is a little ridiculous unless there's, circumstances like circulatory overload. Fresh frozen plasma, we would, for about every 2 or 3 units of blood we give somebody, realize blood just has red blood cells. It doesn't have your clotting factors. It doesn't have platelets. So, first of all, let's talk about platelets. Platelets are your thrombocytes. What's the normal range for thrombocytes? 150 to 400,000. When we drop below 150,000, that's thrombocytopenia, and they're at risk for bleeding. We're looking for petechiae, purpura, oozing around any kind of sites because we're worried about them going into DIC, which we'll briefly mention, but we'll really get into for the third test. Then we have fresh frozen plasma. That includes your clotting factors that your liver manufactures. Okay, that's about 200 to 250 mils. And then you have albumin. Remember what albumin is? If you guys heard my fluid and electrolytes, albumin is the moon. It is big Al. Albumin. 3 syllables. Our albumin should be greater than 3. Albumin, it transfers all kinds of hormones and different things, but the main thing it does is oncotic pulling pressure. It helps keep the fluid in the river to promote perfusion. We all know what people look like when they have low albumin. What do? They third space. Fluid leaks out of the river, out of your pipes, into the interstitial space, and it messes with diffusion, and it messes with perfusion, okay? So albumin is available between 5% and 25%. A lot of times they'll put it in TPN, which we're going to talk about a little bit later. It's the major plasma protein, which determines oncotic pressure. All right. Then we have cryoprecipitate, which is prepared from fresh frozen plasma. It is specifically for replacing factor 8 and von Wilhelm's factor and fibrinogen. And we'll be talking about DIC in a few weeks, but fibrinogen is what makes fibrin. And fibrin is that sticky, it's like an analogy is like a spider web. It lays down within the pipes, little small capillaries, and then your thrombocytes, your platelets, stick to it and make a thrombus. So if you don't have enough fibrinogen to make fibrin, your little platelets are going to be rolling through your pipes, not sticking anywhere. Okay? So that's what that's all about. Okay, so the two different things you need to determine is the difference between an acute hemolytic reaction due to an immune response because we gave them an antigen. That's the number one cause. And a febrile reaction. So when we hang the blood and we start it, the RBC antigen antibody incompatibility leading to red blood hemolysis, it's caused mainly by mismatched blood. It's going to happen within that first 15 minutes. So we're going to stay there. We're going to look for fever, chills, low back pain, because if they start hemolyzing, breaking down those red blood cells, it will clog their kidneys. They're going to feel anxious. They may look flushed, chills, headache, chest pain. They might have heart dysrhythmias. They can go into hemolytic shock, disseminated intravascular coagulation, where they start losing all their clotting factors, kidney failure, and death. A blood sample will show a rise in the hemoglobin because we're breaking down those red blood cells. What do we do immediately if we see that? Just makes sense. Stop it! Am I going to flush that site? No, because if I flush it, any of those red blood cells that are in there are going to go further in, okay? I would pull back and try to get anything out of there. I wouldn't let go of that IV because my whole vasculature may clamp down, and that might be the only site I have. I'm going to get saline running, hopefully through another site, but if not, use that site, okay? And I'm going to immediately get, that is a rapid response, okay? Because these people are going into an anaphylactic reaction, so they're going to need antihistamines like Benadryl, and they're going to need the sympathomimetic drug epinephrine, because it's a bronchodilator, okay? And we need to get a hold of the physician. We need to take the blood, bag it all up, make sure all the bands and everything are set to the lab so we can figure out how that happened. And the person's going to ICU. Okay, it's no joke. All right, now that is less common. In all the years that I've given blood, I've never seen a hemolytic reaction. Thank you, God. Okay, I've seen many febrile reactions because we've checked the blood for the ABO compatibilities, and they try to get the white blood cells out of the blood, but not all the time do all the white blood cells go out. So two things: if somebody has had blood before and has had a febrile reaction, we'll put a leukocyte filter on it, which will trap any white blood cells so they don't get into the patient, because white blood cells have their own antigens. They have the human leukocyte antigen on them. So if you give me your crazy, furry white blood cells that I'm not used to, it's going to cause a reaction in my body. But usually this is much more mild. It's due to sensitizations because of the donor's white blood cells. Could be due to the platelets, though, and plasma proteins, because they're not the same as mine. They're going to have different antigens. You're going to see an increase in temperature, usually greater than a 1 degree Celsius. They might get chills, muscle pain, and headache. But notice, not flank pain. They're not having difficulty breathing. It's much more mild. So you're going to slow down or possibly stop it for the moment till you get a hold of the practitioner. And then they're probably going to have you give them some acetaminophen, some Tylenol. and an antihistamine, like Benadryl, or possibly even some steroids, okay? So that's why we stay in that room. We already talked about anaphylactic reactions, so I'm not going to belabor that point. Turn the page there. Some things that we don't think about, y'all, besides the mild reactions and then hemolytic reactions. They can't have a mild allergic reaction. They're sensitive to some of the foreign plasma proteins. It's most common. If you have a patient who has a lot of allergies, be aware. This might happen to them. They might get itchy. They might get some flushing. But again, it's nothing with their breathing. Their vitals remain pretty stable. They might get a slight temp. We're going to treat them prophylactically with antihistamines and possibly steroids. And what in red blood cells, we try to get it in within 2 hours. The practitioner might say, put it in slower over 4 hours. Now, don't forget this. A lot of the time, we're giving these blood transfusions to elderly patients whose pumps are pooping out. So we're putting more volume in the river, which is taxing that pump. So one of the big things you have to worry about is circulatory overload. So be looking for things like increase in respiratory rate and effort, dyspnea, a cough, you're listening to crackles, distended neck veins. Again, if somebody has pulmonary edema, you know what to do. Stop fluid, get them in high Fowlers, put them on high oxygen, and then try to get some of that fluid out. Get them some diuretics. Okay, septic reaction, I've never seen this either, and we've gotten really good about screening blood. So it's very rare. It occurs to clients receiving a transfusion that bacterially became infected. Symptoms are rapid onsets of chills, high fever, vomiting. Treat septicemia, because now this person, if we put bacteria into their bloodstream, they're going to get septic and they may go into septic shock. So we have to be aware of that. And we're going to have vasopressors like dopamine and epinephrine. We're going to be talking about septic shock in 3 weeks, but here's the deal. When we get any kind of microorganism into our bloodstream, okay, it's toxic. There is a toxin that breaks down the endothelium of our pipes. And our pipes are supposed to be closed so that the fluid just keeps flowing until we get down to the capillaries, and then it's selective at letting how much fluid goes out to the cells. At this point, it will make the capillaries very permeable, and you'll lose a lot of fluid. So anytime somebody goes septic, we're going to be thinking about giving them vasoconstrictors, vasopressors. And then there's a thing called a transfusion-related acute lung injury. And what happens there's a reaction between the transfused anti-leukocyte antibody, we're talking about white blood cells, that affect the patient's white blood cells, causing pulmonary inflammation. And this is a non-heart-related pulmonary edema. They get fever, they get tachypneic, they get that frothy sputum, dyspnea. They're going to be hypoxic, go into respiratory failure. So these people are probably going to have to be intubated, put on a vent, high O2. So you want to get a stat chest X-ray, draw ABG, send for serum labs so they can look for anti-leukocyte antibodies, identify the donors who are implicated, and do not allow them to donate anymore, okay? And you can have massive blood transfusion reaction. Can occur when we replace red blood cells when it exceeds the total blood volume within 24 hours. So if somebody's lost so much blood that we have to replace their whole volume within 24 hours, a massive blood transfusion reaction can occur. And what happens is a lot of times we're giving cold blood. So it can lead to hypothermia. It can actually lead to cardiac dysrhythmias. Think about why. Because it's low in calcium and high in potassium. If red blood cells start to break down, potassium's going up. We know hyperkalemia kills because potassium kickstarts all the electrical activity. And if I have low calcium, the other thing that drives down the calcium is the preservatives in the blood actually bind to calcium. So you got to watch people who are getting blood transfusions for hypocalcemia. What are the 3 T's of hypocalcemia? Tingling, tremor, and tetany. Tingling, tremor, and tetany. And the 2 tetanic contractions are when you tap here by the facial nerve up by the cheek, and they do this, that's Chavastex, or we pump up the blood pressure cuff above their systolic, and they do the claw. Trousseau's. Okay, so remember that. Okay. I think that's all we're going to say about that. Okay? Any questions on blood? Yay. Okay, so now we're going to go to neuro. Now you can see that the first page of your neuro talks about stroke, which you went over in level 2. We just put that there because if somebody has trauma and they bleed on the brain, it's just like having a hemorrhagic stroke, and you may see some of the same things. But we're not going to go into detail on that. You can read that at your leisure. You got leisure in level 4? I don't think so. Anyway, I want to go, and let's just do a quick review of the brain. So when we're looking at the brain, when we're looking at the central nervous system, we know that the central nervous system is highly specialized. It controls and integrates all our body's activities, and it's divided into the central nervous system, which is your brain and your spinal cord. And by the way, cranial nerves 1 and 2, because they're fully encased in your brain, are also part of the central nervous system. All of your cranial nerves start here in the brain, but 1 and 2 stay in the brain. So your brain, spinal cord, and cranial nerves 1 and 2 are made up of your central nervous system. And then you have your peripheral nervous system. Remember the neurons, those are the functional cells of the nervous system. They come in many forms and shapes. But the main function of your neurons are excitability. We want to generate nerve impulses, right? You have to have electricity before you have mechanical action, yes? Conductivity, they transmit impulses to other portions of cells. And influence, they have an influence, which is the ability to affect other neurons, muscle cells, and glands within the body by transmitting nerve impulses. Now, just briefly, so you remember, neurons consist of a cell body, the nucleus and the cytoplasm, several dendrites, which are those short little extensions that extend from the body, and they're what bring in messages to the neuron, and then axons, long dendritic things that take that impulse away to other nerves and other body cells. Those axons range in sizes. They can be myelinated and demyelinated. Remember, myelinated is like having an electrical cord, like right there, that has a plastic casing, right? It helps that electricity continue to go quickly and the way it's supposed to go. What happens if the cat chews through half of it, other than the cat dies, right? You short out your electrical impulses. Same thing when people have MS and they have problems with that myelination, it's going to decrease nerve impulses. Also, when we have spinal cord injuries, if that myelination is affected, we're going to have the same issues. Now, one thing that's important for you all to know, that glial cells are your supportive cells, glial cells, because they take up most of the room in your central nervous system. They're made up of astrocytes, and they also oligodendrocytes. They produce myelin, and they produce myelin in the central nervous system, where your Schwann cells produce myelin in the peripheral nervous system. They make up more than half the brain and spinal cord. That's why astrocytes, that's why glial cells are your primary type of brain tumors, glioblastomas. They're the primary type of brain tumor because they're the most abundant form of cells. Astrocytes provide structural support to neurons and help form the blood-brain barrier, and the blood-brain barrier with the endothelium of all your blood vessels. And we know that that blood-brain barrier helps try to prevent toxic things from getting into our central nervous system. But there are things that will cross it. Now, let's talk about the brain. The brain, this is the motherboard of our bodies, right? It tells our bodies what to do. It brings in information, processes it, and then sends it out motor tracks so our body responds. We have the cerebrum, we have the brain stem, and we have the cerebellum back here. The cerebrum, we have the right and the left hemispheres, and they're divided into 4 lobes. Just briefly, guys, the frontal lobe, higher cortical functioning, memory, voluntary motor movement of our muscles. We have the temporal, right? And I remember the temporal is like right over my ears here. The temporals have a lot to do with speech. Remember the 2 speech areas, because I heard that this was on NCLEX, okay? So the way that I remember this is if somebody's had a brain injury,